It's finally okay to talk about mental health issues far more broadly than before. But as the stigma around mental health issues has receded thanks to years of concerted effort, some experts are now concerned about a different potential problem: the eagerness of some, particularly young people, to get a diagnosis. Is this a good problem to have, or just a problem? Let's ask. In Geneva, Switzerland, Dr. Quam McKenzie, CEO of the Wellesley Institute and a psychiatrist at CAMH, the Center for Addiction and Mental Health. In San Diego, California, Jean Twenge, professor of psychology at San Diego State University and the author of iGen: Why Today's Superconnected Kids Are Growing Up Less Rebellious, More Tolerant, Less Happy, and Completely Unprepared for Adulthood. In Vancouver, British Columbia, Dr. Thomas Unger, staff psychiatrist at St. Michael's Hospital and a professor of psychiatry at the University of Toronto. And here in our studio, Dr. Ralph Lewis, child and youth psychiatrist at Sunnybrook Health Sciences Center and an assistant professor of psychiatry also at U of T. And we're grateful to all of you for joining us here on TVO tonight. Ralph Lewis, going to start with you because it was your piece in Psychology Today that got us thinking about this topic. So I'm going to read an excerpt of that, and then we're off to the races. Sheldon, if you would. Something strange has been happening, you write, in the psychiatric clinic in the last few years. Large numbers of people, particularly teens and young adults, have been seeking psychiatric assessments, certain that they are suffering from a mental illness and quite insistent on obtaining a diagnosis for anxiety, major depression, ADHD, autism spectrum disorder, PTSD. Not that their life stresses aren't challenging and their distress real, but their difficulties typically fall short of the criteria for diagnosis and seem within the range of normal. What's going on? How did we go from the destigmatization to the desirability of psychiatric diagnoses almost overnight? All right, let's dive a little deeper down on that one. Your experiences in the clinic that led you to believe that this was the case. Give us an example.
Thank you, Steve. Steve, I've been a psychiatrist for 26 years, treating youth and young adults. I very much enjoy working with this population. I love this population. My kids are in this generation. When I started out, kids used to be dragged in, you might say, by their parents, embarrassed, mortified to be seeing a psychiatrist, and generally quite resistant to any suggestion that they may be suffering from a mental disorder. With exceptions. Not all kids were like that, of course. But these days, interestingly, the kids themselves are very often requesting consultations with a psychiatrist, in fact, insisting or demanding that their parents and primary doctors send them to a psychiatrist. Now, let me be clear, some for very good reason, and I'm so glad that they feel comfortable doing so, and they're definitely coming to the right place. But increasingly, there's a larger and larger proportion of kids, my colleagues and I have noticed, who are presenting with, you might say, mild to moderate distress and stress. They may or may not meet criteria for something like a depressive disorder or an anxiety disorder or another mental disorder, but the threshold for seeking help has lowered. And so an example might be, let's say, and let me be clear, whenever I give examples, I'm creating a composite example in my mind to protect individuals' confidentiality. So let's say there's a 17-year-old grade 12 young woman who comes to my office and tells me she thinks that she has suffered from major depression for many years, and yet objectively is not doing too badly, is doing quite well academically, has a good circle of friends. According to her parents, frequently enjoys social activities, is enthusiastic about various extracurricular activities and sports.
And yet wants a diagnosis that something is wrong.
And is disappointed, crestfallen sometimes, when I offer a reassuring statement, an encouraging statement saying that, no, I don't think that this is a mental disorder. And of course, I try to empathize and say, yes, life is stressful, you're having a difficult time, but this isn't necessarily a psychiatric disorder, and I don't think medication is what you need.
All right, that's the thesis. Let's get to your colleagues now, and we'll find out some feedback from them on what you have discovered. Okay, Jean Twenge, get us continuing on this path here. Is this something that you see in your practice as well?
Well, to be clear, I'm not a clinical psychologist or a psychiatrist, so my expertise is in looking at generational trends, in particular, generational trends in mental health, say among teens and young adults, the population that we're discussing here. So what's interesting is that I would agree that there has certainly been more destigmatization of mental health issues, that young people are talking about them in person and online quite a bit more than they used to, and it's become much more acceptable. However, there's a separate trend that rates of depression in this population have skyrocketed. They doubled in just an 8-year period. And we know that from data from the US, from the UK, Canada, pretty much all the English-speaking countries, we see this increase in depression. And that's in screening studies of the whole population, where it doesn't matter if you sought treatment or sought help or admitted to something online. These are anonymous surveys. But it's not just admitting to symptoms. We see the same trends in behaviors. So emergency room admissions for self-harm, like cutting or taking too many pills, have doubled or tripled in this population, including among very young populations. 10 to 14-year-old girls is where we see the biggest increase. And most tragic of all, we also see really big increases in this population in the suicide rate. So given that this shows up in behaviors, this is a real trend. So we know it's not just due to help seeking or wanting treatment. So I think maybe the causation goes the other way, that we have a true increase in mental health issues, at least in terms of anxiety and depression. And then that leads to a lot more discussion. And in this population, yes, there may be some influence there of almost like everybody's doing it. We have so many more people with anxiety and depression, and that may lead people who don't actually meet criteria for these disorders to start thinking maybe they have them and showing up at psychiatrists' offices or doctors' offices. So I basically have some areas of agreement and some areas of disagreement here.
Okay, understood. And thank you for clarifying off the top. I guess I shouldn't have used the word practice. I should have said in your world at San Diego State University. So thanks for clarifying that. Quinn McKenzie, come on in here and tell us your view on what you've heard so far.
Very, very interesting. And I did just want to say two things. I know it's not the intention of anyone here, but I wanted to ensure that no one's put up by the discussion and people continue to come forward with their mental health problems. It takes a lot of courage to come forward and say you have a mental health problem. And I wanted to assure that there is effective treatment available. So I wanted to say that. I also wanted to say that some people will be watching this show and they'll say, I really don't know what's going on, because they'll say in their world, the problem is that people are suffering because they can't get help. And whether or not overdiagnosis is an issue, the overwhelming health issue that we have is that we underfund mental health services, and most people complain that they can't get access to care and there are long wait times to see anyone. And if you're outside Toronto, in remote or rural areas, simply the problem is you can't get care. And if you're a racialized group or an Indigenous group, the lack of access to culturally appropriate treatment and concerns that treatment will be discriminatory is really a problem. So I think it's important to say, yes, I think we should find out what's going on and work out what's going on in some of these Toronto hospitals. But we shouldn't forget the bigger picture here.
Quam, I'm going to do a fast follow-up with you, because if I'm reading between the lines here, it's almost as if you are concerned that maybe the Minister for Mental Health Issues, federally or provincially, might be watching this program, seize upon it and say, aha, see, we don't need to put as much money into this as these doctors all claim we do. Is that a concern you have?
I think that there is a concern that sometimes well-meaning narratives can be hijacked by other people. But it's two things. One, that people might say, OK, well, perhaps we don't need more health spending. But it's also the other possibility that people will say, well, I don't know whether I'm going to go forward and ask for help. I don't know whether I'm going to go forward and ask to see if I have a diagnosis, because maybe the psychiatrist will just say that I haven't got a problem. And so I just wanted to reassure people that there's effective treatment available, and coming forward and disclosing your mental health issues and having that discussion is a really important thing to do.
Gotcha. And thanks for putting that on the record. Thomas Unger, your view.
Yeah, so I totally agree. It's great that we've destigmatized some of the mental illnesses and the language, and people are coming forward, and I encourage people to still do that. We have seen a significant increase, particularly in youth in emergency rooms. That's very real, and in the rates of the disorders. But just to speak to the overdiagnosis, I don't know if it's overdiagnosis, but we've contributed to this in our field because the name we use for these disorders are also the same words we use for normal feelings. My hockey team loses, I'm depressed, time to get help. And you don't want to take away that sadness or suffering. So really, we have not really done a very good job differentiating the demarcation point between normal symptoms, normal emotions, and when we think it's a cause for concern. We've labeled these disorders with these names, and every area in medicine goes through this. First, you realize there's some kind of a health problem, and mental illness is not mental health. We don't even want to use the word mental illness. Everything's now mental health. It's like physical health versus physical illness. So every field in medicine goes through this. We cluster symptoms together. We call it a syndrome. We give it a name. And then later we figure out what's going on. Is there junk in your lung? Is there high sugar in your blood? And then we figure out the cause. So in psychiatric disorders, mental illness disorders, mental health, we're at the stage where we cluster these syndromes. We're getting the correlated physiologic things going on with it, but we're kind of stuck there. But really, perhaps our wonderful words that we want to temper everything to make them politically acceptable and bring people forward, which we want to do, like mental health rather than mental illness, is having the side effect of creating everyone thinking that their experience, and youth with that time of emotional turmoil, suddenly needing help and having a diagnosis, which may get them a lot of attention, a lot of support, maybe even some accommodation. So it's a good side effect of this problem that we're encouraging people to come forward and talk about these issues.
Ralph Lewis, let me see if we can better understand what's in it for the young people to come forward and get a diagnosis for whatever it is they're feeling. What's in it for them?
Well, first, Steve, let me just say that I'm so glad that Jean and Quam made the points they did about not wanting to discourage people from coming forward if they think they have a mental health problem. Destigmatization is far from complete. And that would be the last thing I would want, is to give the message of discouraging people from seeking help. I think Tom articulated the problem very well, the demarcation problem. But let me speak to your point, right? What's in it? So life is stressful for young people. Without a doubt, it's been very stressful during the pandemic. But to be clear, the trends that we're talking about go back probably approximately 2 decades. And so the points I was making were mostly pertaining to pre-pandemic. Life was arguably more stressful for young people than ever before. People may dispute that. A diagnosis offers validation, and it offers an explanation for why people are having the difficulties that they're having, why they're struggling, why they feel that they're functioning suboptimally. But I think it's a very complex cultural phenomenon. I think that there may be an element for some kids of unhealthily becoming a little too attached to the identity of someone who is impaired and sick and disabled. Again, that's only a subset of kids, but it's a noticeable trend. I've heard kids say to me that they feel like in their peer culture, they need some sort of official, as they often put it, explanation for why they are stressed and distressed.
Well, having said that, and okay, Jean Twenge, let me get you in on this. If you're in your 20s today, you have firsthand memories of 9/11, of the Great Recession, of living through COVID and Donald Trump, and now there's a war. So if you've got some Eastern European lineage, there's a war going on in Russia or Ukraine, which may be taking an impact out on your parents or grandparents. You've got plenty of reasons nowadays to feel miserable, do you not?
Well, so did the people who lived through the Great Depression and those who lived through World War II and the baby boomers in the U.S. who were drafted to fight in Vietnam and the Gen Xers who lived through the time of extremely high violent crime in the early 90s. So every generation has one thing or another going on in the world that is stressful. What's curious about this increase in depression and self-harm and suicide in the last decade is violent crime, until very recently, has been much lower than it was in the 90s. Unless, as you pointed out, you have relatives in Eastern Europe, it's peacetime. The period from, say, 2011 to 2019, when we saw the largest increase in mental health issues, the economy around the world was doing very well. So it's a real mystery to say, why did we see this increase starting in 2011 or 2012? When I first started to see these trends, I had absolutely no idea what could be causing them because, if anything, they were misaligned with the state of things in the world. But it may not be a coincidence because the early 2010s is when smartphones became predominant and when social media use among teens and young adults moved from optional to mandatory. In a very short period of time, you went from, some people are using these technologies, to almost everyone is. And young people started to sleep less, and they started to spend less time with other people face to face. And that is not a good formula for mental health, particularly when it comes to anxiety and depression. So the pressures of technology, which young people and all of us live with every day, and it affects people's everyday lives, I think is the most likely explanation, because a lot of these other events, most of them, with the exception of the pandemic, didn't have much of an impact on people's day-to-day lives. But the way young people spend their time outside of school and work is completely different now than it was 10 or 15 years ago. And I think that has clearly had a big impact on their mental health.
Okay, let's pursue that angle, Quinn McKenzie, because, Jean Twenge is absolutely right. It's not as if previous generations didn't have their issues, from Spanish flu to World War I, World War II, Korea, Vietnam, and on it goes. So do you want to lay this at the foot of social media as a potential explanation for why this particular generation seems to be having so many more difficulties, and certainly thinks it does, than previous generations?
Well, I think there's a lot of things going on. Let's just get back to basics. When society and mental health systems are working properly, the majority of people with mental health problems are successfully dealt with by individuals, their family, friends, and communities. For a minority where that's not enough, they are seen by family doctors, and for a minority where that's not enough, then they're seen by mental health specialists. So there are usually loads of different levels that you need to go through before you end up getting a diagnosis from a psychiatrist. The problem is that things aren't working properly. Communities are more siloed. Social cohesion is going down. There's less connectivity, and actually, in the UK, they've ended up having a minister for loneliness because so many people are lonely. So communities have decreased abilities to support and treat people who are distressed. So more people go to family doctors. But during the pandemic, say, for instance, the availability of appointments has been limited. So more people go to the emergency departments, and then more people are seen by psychiatrists. But the problem isn't necessarily people. The problem is that we need to beef up our community and primary care supports for mental illness. And if we do that, then people will get the appropriate support in the community than they need, rather than being referred to people who may prescribe. So I think there is something about changes not only in society, but also in the way society is responding to social stress and anxiety, which is allowing more people to move to professional care rather than being held and supported in communities.
All right, let me set up my next question for Thomas Unger by putting some numbers on the table first. And this speaks to your issue, Dr. Lewis, about pre-pandemic. This is not just over the last couple of years. This goes back well before that. So, Sheldon, let me have, if I can, top of page 3. In a pre-pandemic survey, the American Psychological Association found Gen Z were significantly more likely, 27%, than other generations to report just fair or poor mental health. And that includes millennials, who come in at 15%, Gen Xers at 13%, baby boomers only 7%, and older adults, who you'd think have been through, they've been through a lot, 5%. And let's follow up. Only 45% of Gen Z reported very good or excellent mental health, compared to, for example, 70% for baby boomers. So, Thomas, let's try this. More youth coming forward saying, I'm concerned about my mental health. I think everybody here tonight agrees. That's a good thing. People should be on top of their mental health situation. In which case, let's say there is an overdiagnosis of problems. What's the harm?
So part of the psychological issues that we've been seeing in terms of how people cope with anxiety, again, mental health is not mental illness. So they're using this term of mental health around all their mental distress. And sometimes they're coming forward because they don't know where else to go with that. And the fact that we're interchangeably using the word mental health with mental illness is somewhat of a problem. The other thing we've been talking a little bit about, although we don't want to hang it on it, is that people in their development, youth, often have to experience what we call manageable empathic failures. You fall down in the park, you scrape your knee. As a child, you're sad. Hopefully your parent comforts you enough. They're not absent. They maybe don't make too big a deal of it. And you grow up with those capacities. And then you hit adolescence, and a lot of disappointments and things continue. With the safety culture we've had growing up, because all parents, myself, want to protect our kids, do the best for them, we are a little bit concerned that they're so perhaps unprepared for some of the normal emotional upsets that we all go through, the failures, that they're really facing some of them for the first time when they hit adolescence, and hence they don't know where to go with them, and they're coming forward without thinking they're a health condition when there may just be normal emotional distress that needs not professional care, not even to be called a mental health problem. It's just called emotional distress and upset.
Can you build on that, Jean Twenge? What's the harm in a young person coming forward and thinking they need a diagnosis when in fact they don't?
Well, I mean, the one possibility is then it is potentially taking resources away from those with more serious issues who may not have the access to care. So it is potentially an equity issue. But I also want to mention, I agree completely, this is another possibility for why we have this increase in mental health issues, and even those that are more objectively measured and not about seeking treatment. Is it's true that this generation, Gen Z, is growing up more slowly. They are more protected by their parents. They don't have as much experience with independence during adolescence. They're less likely to get a driver's license or drink alcohol or go out with their friends or date or have a job. And so they often get to university and don't have much experience making decisions. So this is something else, at least for those young adults, that enters the equation in terms of the rise in mental health issues, because they just haven't been equipped to enter adulthood in the way that previous generations were. And I think it's also important to acknowledge that this rise in depression and self-harm began in the early 2010s, even though these issues around social cohesion and societal breakdown have been going on since the 1960s. And although we had increases in depression from the 60s to the 90s, things actually got a little bit better. 90s, 2000s, things stabilized for young people. So there was some sort of catalyst in the early 2010s that seemed to lead to this increase in depression and self-harm.
Well, Ralph Lewis, let me set up this next question with another comparison between physical health and mental health. If you get a misdiagnosis, say for a heart attack or a stroke or a burst appendix or something, you're in big trouble. In fact, maybe you're dead. Are the consequences similar if you have a misdiagnosis, as we have been discussing, when it relates to mental health?
Well, Steve, for the most part, not as dire as that, but there certainly are consequences. We have to be very wary of over-medicating patients on the assumption that they have a significant mental disorder. The evidence shows that medication is usually needed and most often helpful for serious mental disorders. We don't want to pull that trigger too quickly and unnecessarily. The other consequence is the problem of swamping, overwhelming the mental health system, which prevents people with more serious mental disorders from seeing psychiatrists and getting the help they need.
So that's resources allocation.
That's right.
Again.
Wait lists get longer and longer. Now, part of this is very much our fault as a profession. As a mental health system, we should have much more stepped care, a tiered, stepwise access. People should not, a psychiatrist should not be the first port of call for someone who thinks that they may be experiencing depression or anxiety. So the... And then the other thing is just, inadvertently reinforcing people's sense of being disabled and being incapable of coping in life. It's the opposite of promoting resilience. And if I may just add one point about this generation further to Jean's point, this is actually a wonderful generation in many respects, where the generation loosely referred to as Gen Z, or in the US, Gen Z, and late millennials. There's actually a lot less of other kinds of mental health problems. For example, juvenile delinquency. Now that's not the official term. Conduct disorder is what we call it. Remarkably, this has gone down. And a whole lot else has gone down, including drunk driving and teenage pregnancy. And I could go on. And Jean is the expert on this. But it's a much nicer generation in many respects. They're also much more sensitive to social justice issues and a whole lot else. But we do need to help them to be more resilient and to self-identify as more resilient.
Well, in our remaining moments here, one teenage girl who was a patient of yours, who you thought did not meet the criteria for a disorder, had this to say, and Quay McKenzie, I'll get you to reflect on this. This patient said, "I would like a diagnosis so I know that something is going on and I'm not faking it. So I have a valid reason to feel awful sometimes and not have people get on my case about it." Now, anybody with a daughter of this age can relate to that kind of sentiment. Dr. McKenzie, what would you say to that person?
Well, I used to do polls of my patients to talk about diagnosis. And about 50% of my patients thought diagnosis was useful. About 50% of them thought labels were for cans of food and not for people. But 100% of them wanted effective action to help them with their suffering and their problems. And I don't see that openness to discussion of mental health issues is a problem. I think it's an opportunity. I think the issue is what we do about it. We have a gift of people coming forwards and saying they need help. And the question for me is how we use that to build mental health literacy so that we can deal with this, I need a diagnosis in order to legitimize my being. How we build individual and community resilience, and how we create more supportive workplaces, schools, and societies. I was reading the new National Institutes of Clinical Excellence guidelines on the treatment of depression and anxiety, which comes out of the UK. And they are set to announce that the first line, evidence-based, cost-effective treatment of mild depression and anxiety will be a structured exercise program or group CBT. So they're going towards offering exercise or building skills for psychological resilience as the way of dealing with this issue. And it may be that rather than saying, hey, what's going on with these kids, our question should be, how have we not pivoted to be able to give people what they want? I mean, Gen Zs is 1/3 of the population. So maybe we have to think about, just as Dr. Lewis said, how we set up our system so that they are given the right skills and supports close to home in community rather than medicalizing their distress.
Thomas Unger, in our last minute here, maybe you could weigh in on that as well. It's almost as if this young patient of Dr. Lewis's was looking for a diagnosis to, in some respects, explain and or accept just the condition of being human. What do you say to that person?
Yeah, so this is where the skill, the judgment, the tact of a good clinician comes in to help differentiate what is just normal suffering and not give a diagnosis where it's not warranted, as opposed to diagnose those who really do have what we consider a mental illness. Because when we can explain a diagnosis to someone who warrants it, it often is very welcome. It gets them off the hook. They no longer personalize and have all those self-stigmatizing thoughts of I'm weak, it's my fault, what does it say about me? Instead, it's just a health condition that's happening to them that we can treat, and it's not about them as a person. So that judgment and tact to make sure that we don't overdiagnose, that we help tell them it's normal, humans are strong, they can adapt, we can grow, and we will triumph is a hopeful message, but still support them through those moments of emotional distress.
Great. Thanks so much, you four. That was a great discussion tonight. Out of town, Jean Twenge in San Diego, California, Thomas Unger in Vancouver, British Columbia, Quam McKenzie in Geneva, Switzerland, and here in our studio, Ralph Lewis. Great to have you all on TVO tonight. Many thanks.
Thanks for having me.
Thank you, Steve.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.